I have never seen anyone able to squeeze so much into one meal. He will go down to Chile. Friday night. He will ski Saturday, Sunday. He will come back, start on the ICU on Monday, do his Thursday afternoon clinic, take the red eye to God knows where in Europe or somewhere else and make it back. He's productive not only in athletics, but also as a pulmonary arterial hypertension specialist. If you go through the history of PAH, it wasn't that long ago that the classifications made no sense and there were no treatments. And there was a small cadre of people who committed themselves to understanding why the disease developed and coming up with treatment strategies for that, for the disease. The disease without treatment has a life expectancy on the order of 1 year to 2 years, depending on which cohort you look at. And so it really was something that needed to be addressed. And happens among probably 5 to 10 people who was there at the beginning and continues to be there today. So I was talking to Samina Hyatt about PAH and connective tissue disease and how big a challenge it can be diagnostically and therapeutically. And we thought it would be fun to have Hap come back and give us an update on PAH and connective tissue disease.
Okay. Well, thanks. The crutches are just for sympathy. No, actually, it's a pleasure to be here. So we're going to talk about, this is hard because normally I run around and walk and all this stuff. But anyway, so pulmonary arterial hypertension with connective tissue disease. And these are my disclosures. And what we're going to talk about are 3 things. So the background, the treatment, and the future. And just for this talk, most of what we're going to talk about when we're talking about connective tissue disease is scleroderma, or actually more accurately, the scleroderma syndrome, or the scleroderma spectrum of diseases. So it's not just necessarily limited or diffuse scleroderma, it's also scleroderma associated with mixed connective tissue disease or overlap syndromes or whatever. But anything that has scleroderma in it, and why scleroderma is the most or more important than the rest of the connective tissue diseases you'll see here in a minute, okay? So if you look at the most recent classification of pulmonary hypertension, this is from Nice 5 years ago. There was actually the meetings are every 5 years, okay? So there was just one in February. So some of this is probably going to change, which, not probably, it will change, but you can't release what's actually going to be out there till it's finished and published, which is usually in December, so it'll be December of this year, okay? But you can see that connective tissue disease falls here under pulmonary arterial hypertension. There are 5 groups of pulmonary hypertension, which we're going to go through real quick. Connective tissue, as you'll notice, is the top of what's called associated PAH or APAH, and the reason will become evident soon. So these are basically systemic diseases in which PAH is far greater than what you would expect in the general population. The other 4 are HIV infection, portal hypertension, congenital heart disease, and schistosomiasis, which is actually the most common cause of PAH in the world. Then groups 2, which is probably the most common cause of PH now in the United States, which is due to left heart disease, especially this. Diastolic heart disease, it's just rampant. I mean, it's an epidemic. So the thing that's important to start with is everybody who has PAH has pulmonary hypertension, but very few people who have PH, pulmonary hypertension, actually have pulmonary arterial hypertension, okay? And then group 3 is basically lung diseases or hypoxia, mostly either COPD or some form of interstitial lung disease. Group 4, which is even more important, is nowadays is chronic thromboembolic pulmonary hypertension, which seems to be more prevalent than we used to think, probably just because we're looking for it. But it's the only form of PH that's actually curable if you have disease that's amenable to surgery. And then pulmonary hypertension with unclear multifactorial mechanism, which is basically anything I'm talking about. The major ones in there are some of the myeloproliferative disorders, sarcoidosis, and chronic renal failure if you're on hemodialysis. And we can talk about those separately at the end if we need be. So why is the issue of scleroderma PAH important? Well, it's important for the following reasons. So if you look at echo data, about 6 to 60% of people who have scleroderma have pulmonary hypertension. But since we know that echo has about depending on who you want to look at, somewhere between a 30 to 40% false positive rate when measured against cath. If you look at cath data, about 8 to 12% of people who have scleroderma have pulmonary arterial hypertension by right heart cath. So that's 1 in 10. I mean, that's a lot of people. Now, it turns out, though, that obviously PAH is a orphan disease, so there are less than 100,000 people in the U.S. with PAH. Actually, as it turns out, scleroderma is also an orphan disease. So there's around 98,000 people with scleroderma in the United States. So that you have 2 orphan diseases, and yet 1 in 10 people with those have the 2 together. So you start thinking that, maybe there's something here that we're missing, okay? Now, the other reason that it's important is if you look at any registry data or any of the pivotal or any of the clinical trials that have been done in PAH, connective tissue people, especially scleroderma people, make up the 2nd largest group behind idiopathic or heritable. So not only is it important because a lot of people who have scleroderma get it, but it is the 2nd largest group. And as you'll see, up until recently, we've done a pretty lousy job with them as far as treating them and outcome. And I'm not sure that we've still done a good job, but we'll get to that. So why is it important? So 80% of people who have scleroderma spectrum of disease develop either PAH or interstitial lung disease. That's a lot. And currently, PAH and ILD are the major cause of morbidity and mortality in people with scleroderma. Okay, it's the cause of death in greater than 50% of people. And this is in part because rheumatologists have gotten pretty good at keeping scleroderma patients alive. Okay, as it turns out, in the last 20 years, the median survival has gone from 5 to 10 years up to about 20 years. So they live longer. 2 is the incidence, for whatever reason, of scleroderma renal crisis and scleroderma renal failure has gone down dramatically. And the incidence of managing GI disease and the malnutrition from that has gone up. So that lung disease is now the biggest problem in people with scleroderma. Once we figure this out, cardiac disease is next, okay, which we'll probably touch on too. But what's fascinating is if you look at autopsy data from people with scleroderma, and there's one study in the literature that's been done, it's old, but these were people who died presumably of not pulmonary causes from their scleroderma, and yet 65% of them had changes in their vessels that were consistent with some sort of pulmonary vascular disease. Okay, so you're sitting there thinking, wait a minute. He's feeding me, okay? These numbers don't add up. So how can only 8 to 10%, or about 10% of people have PAH, yet 65% of people at autopsy have some sort of pulmonary vascular disease? Why? What's the discrepancy? So what is the discrepancy? I have no idea, except there are a couple possibilities. One is that back then in the autopsy data, people did not, with their scleroderma, did not live long enough to clinically manifest the disease. So that's one possibility. 2 is that there are a lot of people out there with scleroderma who have changes to their pulmonary vasculature, but it's subclinical. So they never actually express the disease. Possible. Or 3, we're lousy at picking it up, which is certainly possible. Okay? So it turns out that if you develop PAH, realistically, you got to wipe out about 50+% of your vasculature before you're clinically symptomatic. How's that possible? Well, God gave us too much lung, basically. So we have twice as much lung as we actually need. So if I do a pneumonectomy on Keith, for example, right now, he will not have pulmonary hypertension when I'm done with him. Okay, assuming that the rest of his lung is normal. Okay? So you can knock out 50% of the vessels, basically, and not be symptomatic. Okay? So you can have these people who run around with the subclinical disease, and as long as they haven't involved more than 50% of their vessels, they may be completely asymptomatic. So I think it's a combination of a lot of stuff, but the bottom line is it's probably more prevalent than we think, and it actually is associated with any form of scleroderma. It had been said in the past that you really only got this disease if you had limited scleroderma, which is not true at all. You can have diffuse scleroderma and have PAH. You can have actually what's called scleroderma-associated scleroderma. So these are people who have scleroderma, but they don't have the skin changes. So if you look at their fingers and stuff like that, they look totally normal, but immunologically, they've got the disease. Okay, so it doesn't really matter what form you have. Now, there is a higher risk if you have limited disease, probably because it's a more vascular form. There's also the risk is the late age of disease onset, which makes no sense when you think about it. You would think that the earlier you are when you're diagnosed with scleroderma, the more likely you are to develop pulmonary hypertension, but that's not true. Okay? However, if you've had the disease for more than 10 years, that is a risk. Okay? So that gets into this issue that we were talking about, that if you don't live more than 10 years from your scleroderma, even though you may have vascular changes, you may never show up with PAH because you just haven't lived long enough. There are some thoughts that if your Raynaud's all of a sudden starts to get worse, or extends to other things, like say you just had it on your hands, now you got Raynaud's of your feet, or crazy, you can develop your earlobes or your tip of your nose. I mean, scleroderma, not so much fun. But think about Raynaud's of the tip of your nose. I mean, that, you know, everybody looks at you and goes, you're drunk all the time because your nose is purple. But anyway, so if your Raynaud's gets worse, that's worrisome. And also if you have decreased or decreasing DLCOs, that's also worrisome. What's fascinating about the DLCO is if you do retrospective studies of people with PAH and scleroderma, almost all of them have a low DLCO. So you can say that's perfect. But if you do prospective studies, it doesn't hold up. So it's the way you do the study, and it's a biased sample. Okay, so it's such a problem, or such a big deal, that the ACR, which is the American College of Rheumatology, now basically recommends the following. So if you're newly diagnosed with scleroderma, you get a baseline echo and PFTs. And you get, this actually should be changed from considered to emphasize that you should have annual echoes and PFTs. And if your echo is at all abnormal, you need a cath. Okay, plain and simple. So, up until recently, this was important because what was considered more favorable baseline hemodynamics, okay, which is that if you compare people with scleroderma PAH and idiopathic PAH, okay, the people with scleroderma have better hemodynamics. Their cardiac output's higher, their mean pulmonary artery pressure is lower, and their pulmonary vascular resistance is also lower, yet they do worse. They have a worse outcome. They have more markers of bad prognosis, like their BNP or their NT-proBNP is higher. Obviously, their incidence of renal insufficiency is higher. They have poor 6-minute walk, and they do worse. So why do they do worse? Well, there's been a lot of theories as to why they do worse, none of which have actually ever been proven. I mean, the first one that strikes you obvious is, well, they got a systemic disease. Idiopathic disease, you just have PAH. Okay, but scleroderma, you got a systemic disease with all the other problems. Although if you separate it out, that's not clear. Secondly, there's this theory that, well, you probably have right ventricular involvement because you have fibrosis or stuff like that, but you can't actually prove that. So the reason is not actually known, which is what we're going to get into in the second half of the talk. Also, for whatever reason, even though they do worse, up until recently, the people with scleroderma were less likely to get combination therapy and or prostacyclins, which makes little to no sense when you think about it. But it's reality. And people with scleroderma and PAH have more hospitalizations and poorer survival. And we do know, however, that people with PAH, if they're hospitalized, that's a huge risk factor for increase in mortality, morbidity and mortality. In fact, in PAH, the worst thing that can happen to you is hospitalization. It basically is the beginning of a downward spiral. Okay, so what does it mean? Well, if you look, this slide is probably in every scleroderma talk, okay? So basically, if you have, whoops, hang on, we got crazy here. So basically, if you have scleroderma and no lung involvement, your survival is pretty good. If you don't have pulmonary hypertension, not so bad. And with pulmonary hypertension, back then, and you got to remember, this is before there was really good therapy, the median survival was like 2 years. Okay, now we got a little bit of therapy, but you can see that the scleroderma people are down here. Idiopathics are up here. They did lousy. The most recent data on this is from Reveal, the Reveal registry, which, for those of you who don't know, Reveal was a registry of is a registry of PAH in the U.S. It's the largest registry of PAH, not only in the U.S. but in the world. Reveal 1.0 had 3,500 patients in it. Reveal 2.0 just started, and we now have, I think, 250 or 300 people in it. Okay, but what you see here is, okay, if you look at connective tissue disease here, okay, they're down here, okay, compared to idiopathics here. However, if you look, the 5-year survival is now what the 2-year survival was back then. So although we've improved, there's still a long ways to go. Not with any form of PAH, actually, but connective tissue in perspective. Now, there are more recent data where we got a little more aggressive, okay? So the first things I'm going to show you are what's called SERAPHIN. This was the study of macitentan, which is an endothelial receptor antagonist for PAH. So basically, the study is very simple. People were on background therapy of a PDE5 or not and had macitentan added, and the 10 milligram tablet, which was the one that was approved, did your risk of a composite endpoint. So your endpoint was death, transplant, hospitalization, stuff, worsening of your PAH, stuff like that. So the risk, if you added the drug on, was dropped by about 40%, which is not bad. Okay, but if you look closely, I don't know how well this projects, here's the connective tissue people. So they crossed the origin. So although it was good for the group, you can't show that the connective tissue people broken out had an effect. However, in the two most recent studies, one is Griffin, which this is adding selexipag, which is an oral IP agonist. It's a prostanoid-like thing, but it works on the enzyme that makes prostanoids, to either no, one, or two background drugs. Same sort of composite endpoint. There was a drop in events by 39%. Not bad. And especially since people were on, some of these people were on two background therapies with both a PDE5 and an ERA. And you got the same effect whether you were on no drugs, one drug, or two drugs. But this time, if you look, so this is systemic sclerosis, and this is lupus. The people who had scleroderma actually got the same effect when selexipag was added as people who had idiopathic disease. Actually, first time it's ever been shown. Okay, then there's the ambition. So what I told you before are people who had already been pre-treated. Now, ambition was actually in incident patients. So these are newly diagnosed, treatment-naive patients, okay? And in this study, you either got started on an ERA, which was ambrisentan, or a PDE5, which is Tadalafil, separately. Both of them are obviously FDA approved. Or you got both drugs up front. So there was no true placebo in this. You either got one drug, the other, or both. And sort of the same composite endpoint, hospitalization, et cetera. And if you got both drugs, okay, compared to the pool monotherapy, it dropped your risk of an event by 50%. in newly treated people, okay? And it didn't matter whether it was ambrisentan alone or tadalafil alone, it was the same, okay? Now, the thing that's really interesting about all three of the studies that I mentioned, SERAPHIN, Griffin, and Ambition, is the drop in risk in all three was roughly the same, whether you were incident or prevalent, and it was all driven by the same thing, lack of hospitalization, which if you think about it is huge because A, it saves money, and B, we do know from REVEAL that in PAH, hospitalization is your worst prognostic indicator. So potentially good. Okay, and then if you look at the subset, okay, these are connective tissue people, okay, and then the bottom is the scleroderma people, and you can see that you got the same effect. All right, so up front, this suggests that maybe you need to be much more aggressive, not just with any form of PAH, but certainly with scleroderma. Okay? Now, what's the problem with these studies? Well, the problem with the studies is most of the people that you know with scleroderma would have been excluded from the studies because there were very strict PFT data to get into the studies. Okay? I can tell you, I work in a place where we have one of the largest scleroderma centers in the world. We have over 1,000 scleroderma patients, 1,100, okay? And we were in all three of those studies, and the majority of the patients we referred couldn't get in because their PFTs didn't fit. You needed an FVC of 70% or greater and a whatever, and a lot of these people don't because a lot of these people have diffuse scleroderma and PAH, and they couldn't qualify. So the question really is what was found in this study pertain to all, or pertinent to all people with scleroderma? We do not know the answer. I can tell you anecdotally, treating a bunch of these people who never would have qualified for the study, in most of them it does seem to work, but probably there's a huge percentage that it doesn't work. Okay? Now, past that, there is a study from Johns Hopkins in which they used Ambition-like protocol. So that in people who just had scleroderma, and this is about 20 patients, and they found sort of the same thing. They had a marked drop in PVR and a marked drop in right ventricular mass overall, although you can see there are people who did not get better in people with scleroderma PAH. Now, this study, although it's sort of adds on to everything we know, has problems, i.e. there's no controls. Everybody got both drugs. Nobody got single drugs. And so it's got a lot of flaws, but it does sort of add on to the data we got. So this is the stuff I do outside of clinical stuff, which is what we're going to talk about for a little bit. So our goal, where I am, and shared with rheumatology, actually I have an appointment in rheumatology too. I'm probably the only pulmonary person who's also an appointed rheumatologist. Okay? Don't show me osteo, though, forget it. Regular osteoporosis, I don't want to know, or whatever. But we had, at the time, now this is 6 years ago, we had the first National Institute of Arthritis and Muscle CORT, which is a center for treatment and study of scleroderma. We had the only one in the country, actually, that was funded. And the idea behind it initially was to try and figure out markers or anything that you could figure out that would be predictive of interstitial lung disease and or PAH in people with scleroderma. And that was the whole idea behind the original part of the study. It's since run its course, and it actually got refunded last fall, and it's moving on, part of which I'll show you later. So we got away from all this functional stuff, PFTs and hemodynamics, because we thought that had all been done, and that was not helping us predict who would. So we got into imaging, proteins, and genetics, okay, which I'm going to show you some stuff. So first off was this study called DETECT. And the idea was to come up with predictors that would tell you whether your scleroderma person was developing pulmonary hypertension. So it was basically divided into two parts. One was echo part and one was right heart cath part. And the idea was you had certain parameters, and if you got a certain number of points, and your total points was, hey, you need an echo. or, hey, you need a cath. Okay, whether you're symptomatic and your echo looks okay or whatever. And so you can see the parameters are things you would have thought of. Okay, and if you got a certain number of points here, which was greater than 300, all these had points, that meant you needed an echo. And then when you went on, if you took these points from step 1 and you did your echo with right atrial area and the tricuspid regurgitant jet, and you added up to a certain number of points, then you needed a cath, period. So you'd think this is perfect. Okay, these guys have this figured out. We're going to make this work. Well, guess what? It didn't work. Okay, so the tech did not work. It turned out it didn't work in some really odd ways, is that a lot of people that were referred in already had pulmonary hypertension, so we'd already missed the boat. And the thing you wanted really is to find these people and find them and then follow them and see if they develop pulmonary hypertension. The problem was there wasn't a long enough time span to do that, because it turns out that if you have a bunch of people, and this was actually part of the court, who don't have pulmonary hypertension, and you follow them, only a small percentage of them will develop pulmonary hypertension in the time frame you're constrained to by a grant. But from that came a whole bunch of echo stuff that did predict pulmonary hypertension. Okay, the problem with it is most echoes don't give you this information, because to do one of these echoes that requires this, they run through echoes in 10 minutes, 20 minutes. These take like an hour to do. But we came up with a whole bunch of parameters. So these were 21 people that we actually put into detect, and they had an echo, a right heart cath, and PFTs on the same day. Okay, and you could find that under those circumstances, your systolic pulmonary artery pressure, your mean pulmonary artery pressure, your PVR correlated strongly with your echo. Not surprising, because they're done on the same day. And your RV systolic pressure could be predicted by your TAPSE, your tissue Doppler, your S velocity, your fractional change in area, but it's not feasible to do that. All right? So, however, though, the idea, since we were doing this grant stuff, was to try and then create phenotypes that were more likely to develop PAH than those that were not. Okay? So that's where this is headed. The problem is we're now doing the prospective part of this to see if we can actually predict it. I'll be back with you in about 3 to 5 years and let you know for sure. So let's move on to molecular biomarkers, because everybody wants a molecular biomarker nowadays. And there weren't any for scleroderma. In fact, there are no genetics really associated with scleroderma. Nobody has any idea why you get scleroderma. There does not appear to be some genetic mutation that automatically gets you scleroderma. So I'm going to show you one, maybe 2 heat maps. I've got thousands, but you don't want to look at them. So basically, we took a bunch of people to start with who had proven PAH, cath-proven PAH from scleroderma, didn't have PAH, and controls, which were mostly the people who worked in the lab. And we did your genetics. We basically sequenced you. Okay? And as you can see, amazingly, the people who have pulmonary hypertension and the people who don't have a very different genetic heat map. Okay? Not only genetic heat map, but cytokine heat maps. Okay? They're very different. And through a lot of studies and all this stuff, what I can show you is basically that what we found is that 9 genes basically predicted whether you had pulmonary hypertension or not. Okay? What's interesting about them is they're all over the place. Some of them you would have guessed might be associated with pulmonary hypertension, but most of them weren't. And the cytokines all were, interestingly, interferon gamma related. Okay? And a lot of the genes were also interferon gamma related. And so the initial stuff suggested that maybe activated monocytes and markers of vascular injury could be used to predict people who had pulmonary hypertension, or were going to develop it. Now, okay, that's great. We knew all these people had it, but what about predictive? Well, it turns out that now that we've been doing this for a while, there have been 3 or 4 people who had this profile and then went on to develop pulmonary hypertension who didn't have it when we started. Or we didn't think they had it when they started, because if you had a normal echo, we didn't cath you. So Potentially, we missed a few, but it suggests that it's there. Then we went a little farther and did what's called nanostring molecular barcoding, which, for those of you who don't know, is like when you go to the supermarket, you have a little barcode on your little product, and you slide it under a thing, and it tells you how much it costs. So you can do the same thing with genes. So you take a string, and you put, say, 100 genes on it, and it makes a barcode. And then you just slide it under a thing, and the barcode tells you how expressed it is or not. It's amazing. Okay, so this paper actually just got published, I think, last week or 2 weeks ago, or it's EPUB. So what we found is when you pick genes, some of the ones we found, and other genes that are more along with vascular biology, with nanostring, it was incredibly predictive. Okay, but what was fascinating about it is there were multiple genes, obviously in addition to being female. 90% of Scleroderma-PAH patients are female. So you could negatively or positively predict, okay, but what was interesting is people who had borderline PAH with scleroderma, when you count them, say their mean pulmonary pressure was 20 to 25, but not 25, had the same markers as the people who already had it. So those people were obviously following to see if they would now develop it. So that would make this even stronger. Okay? So the whole idea is to develop this genetic, basically, profile that predicts whether you're going to develop pulmonary hypertension or not. Okay. So then this is really cool. Okay? If I say so myself, which I do. So this is what we tried to do to take what's known about malignancy to scleroderma. So nowadays, realistically, let's say you have lung cancer. You're not getting treated unless your cancer is genotyped, right? You get treated based on your genetic mutations now. All right, so could we find some markers in people with scleroderma that would predict whether you're going to respond to therapy or not? So we took a bunch of people who had newly diagnosed PAH with scleroderma, and this was back before dual therapy was sort of the paradigm, and they got treated with Tadalafil. And we did genetics on them when they started and 6 months later. It's the only clinical trial done in which genomics was the primary endpoint. Okay, it's actually sort of a cool idea. And surprisingly to me, because I thought this was going to be a total flail, to be honest with you, it worked. Anything associated with IL-12 and extracellular matrix stuff was associated with plus or minus. So we divided people into responders versus non-responders clinically based on how much you improved your 6-minute walk and how much you improved your PVR. You had that both. And then we looked at your genomics. So the genomics people were blinded to the clinical data, and the clinical people were blinded to the genomic data. And then at the end, we put it all together. And miraculously, the genomic data predicted the clinical response. Okay, but what was interesting is not only was it predicted by some of the things you would have expected, but there were some crazy, especially doing bioinformatics and all this stuff, there were biological pathways that were highly relevant to either developing PAH or not that you never would have predicted would be important in PAH. Things like Golgi signaling and all this stuff, which we're now investigating to see whether that actually means something. Okay? But it is sort of interesting that you could predict at least to one drug, okay, in a set of people using really advanced genomic techniques and bioinformatics, who was going to respond to the drug and who wasn't. So the change in genomics actually predicted your response. All right, so we were going to do it with macitentan, but then unfortunately the ambition came along and you really can't put people on single therapy anymore, so we had to scrap it. Now, so let's talk last, and then we'll go into question part, about new drugs. So even though we think we've done better with scleroderma, especially based on the event-driven trials, the recent event-driven trials which I talked about, maybe not SERAPHIN, but clearly Griffin and Ambition, we still aren't even close. So we'll talk about 3 drugs, and I'll talk about the last one in a little more detail. So rituximab, which was originally done for lymphoma and now treats about everything, has been used. Well, why rituximab? Well, there's a lot of evidence, both from us and other people, that innate immunity is somehow important in this, and that if you could eliminate B cells, maybe you could actually have an effect on the disease. Well, eliminating B cells is what rituximab does, basically. So there is an NIH-sponsored trial looking at rituximab added to background therapy of people with Scleroderma-PAH. The trial was for 65 people. There are now 63 or 64 who've been enrolled. So it's a 6-month trial. The data should be, all we got to do is get 1 or 2 more people. So the data should be within a year. And then there's bardoxolone, which for those of you who don't know is an antioxidant, sort of, that had been looked at in diabetic kidney disease and stuff like that, and it failed actually miserably. But the idea of antioxidants in PAH is particularly appealing because you can show a lot of antioxidant-mediated effects in PAH, whether it's primary, secondary, or whatever, nobody really knows. So bardoxolone suppresses oxidants. There is a small phase 2 study that has been completed on about 15 to 20 scleroderma patients where it looked good. The phase 3 study has just started. And the last thing I want to talk about is Tecfidera, which, for those of you who don't know, so Tecfidera is DMF, and Tecfidera is the most widely used oral MS drug in the world. So 3 million people have taken this drug. It's an incredibly potent antioxidant, and so it's been used in MS to suppress basically reactive oxygen species immunity, and actually works very well for MS. So because we had some, Biogen makes the drug, they're in Boston, we had some discussions with them and convinced them that maybe they should study this outside of MS. Okay, so we now have, as associated with our court, we have an R21 from the NIH to do the first open label pilot study of this drug. Now, why that? Well, we actually got the, before we actually even applied for the R21, we have both in vitro and animal data to show that Tecfidera suppresses reactive oxygen species in endothelial cells and smooth muscle cells. And also in an animal model of PAH, it completely eliminates the PAH. Now, whether that means anything in a human, I don't know, but it's pretty much shown since there's no really good animal model of PAH. So if your drug fails in an animal, it's not going to work. If it works in an animal, it might work in a human, not necessarily. So the idea here is to use Tecfidera on background, people with PAH and scleroderma, who are on background therapy, stable background therapy, at the doses that are approved for MS, because we don't know what else to do. It's a phase 2 study, and the primary endpoint is either a change in your 6-minute walk during a 6-month study, powered to detect a change of 35 to 40 meters. And then also looking at changes in PVR and also doing basically biomarkers to see if our biomarkers that we came up with in the original court actually match up to this study. All right? And it's 5 sites. So Cincinnati, Michigan, Hopkins, us, and Pitt. 28 people in the original study, and it's now funded as an R21. And the first patient actually is getting enrolled this week because the grant just went into effect, and we'll see if anything happens. So the goal here really is to take what seemingly has been shown from the newer sort of, if you want to call them endpoint-guided trials as opposed to 6-minute walk trials, and to take people, as you'll notice that in this trial with the Tecfidera, we did not control for PFTs. So we're going to let anybody in with PAH and scleroderma. Because, as I mentioned, one of the biggest issues is the people who were in both Griffin and Ambition are so sub-selected and represent a small population of the true scleroderma PAH patient that I'm not sure it works in everybody. Okay, so there still are people with scleroderma who do lousy with their PAH. So the idea is to try and find other markers and go at this from a completely different way and see if we can change the outcome. Now, the last thing I want to talk about is this, which is anticoagulation in PAH with scleroderma. So for those of you who don't know, anticoagulation in PAH is to say the least, a controversial subject. Okay? So there are anecdotal studies and there are retrospective studies, but no controlled prospective studies to show that anticoagulation might be beneficial in people with PAH. Scientifically, it totally makes sense because if you go way back when these studies were done, people with PAH were basically sedentary because there wasn't good treatment, so they didn't do anything. So obviously they had a higher risk of DVTs and clots. And also, when you have PAH, no matter whether you believe that PAH is a smooth muscle disease or an endothelial cell disease, eventually your endothelium gets damaged. Okay? Once your endothelium is damaged, endothelial cells are damaged, they change from an anti to a procoagulant surface, so that your risk of in situ thrombosis with PAH is dramatically increased. Now that may be less so, especially if you're on a prostacyclin, since it's sort of anticoagulant in its own part. But, so it had been general, it's actually still in the recommendations that people with PAH be anticoagulated, or considered for anticoagulation. So we took Reveal and we looked. And I'm going to show you the scleroderma stuff, but I'll tell you, in the idiopathic disease, it's a wash. You can't prove that it's beneficial, but it doesn't look like it's detrimental. As opposed to scleroderma, the people in Reveal, remember this was 3,500 PAH patients. In the scleroderma patients, out of the 3,500, it was about 1,100. Okay? It wasn't beneficial. In fact, not only was it not beneficial, the people who were anticoagulated actually did much worse. Okay? So there have now been other studies that actually confirm this. Okay? It's much smaller, but on the same thing. And there's been an editorial written on all of this that basically says that people with scleroderma and PAH should not be anticoagulated unless they have some other reason to be anticoagulated. Idiopathics, it's sort of a wash. Any other form of PAH, it should not be also. So that's where that stands. And I think with that, I'm going to close and let you guys ask questions. Okay, so thanks for listening. Okay, and I'll take any questions that anybody can come up with.
So on that last slide, did they do worse because they had bleeding episodes? They just bled more and had complications?
So actually, that's a good question, and I left that so that somebody would ask it. Okay, and it turns out, interestingly enough, they didn't bleed more. Okay, no overt bleeding. Okay, the problem is that people with scleroderma, okay, may not have overt bleeding from anticoagulation like you and I think, like you bleed into your head or stuff like that. So a lot of people with scleroderma have telangiectasias of their gut. Okay, not only do they have it on their face, they have their gut. So they have these sort of low-grade, intermittent or not bleeds. So they get more anemic. So it could be from that. They were more anemic, but we didn't have proof of where they bled from. Okay? But even in the people that you couldn't document bleeding, they did worse. Now, whether the warfarin's doing something else, I have no idea in these people. Okay? But it clearly, not only did we show it first, but it's been shown now in other cohorts. So, for example, somebody went back and looked at all of the patients who've been treated with Remodulin, because United Therapeutics actually has a database of them, who had been on Coumadin or not, and it turns out the people who had been on Coumadin did worse. And it's actually now been shown in the Selexipag group, in the Griffin study, anybody who was on anticoagulation also did worse. Now, obviously you can argue that these are biased populations and there's no randomized prospective study to prove this. True. But the problem is there's never going to be. We've actually approached the NIH to do one. They have no desire to do it. Okay, so the answer is, I think maybe it's from low-grade bleeding, but I don't know for sure that it isn't some other maybe off-target effect. Okay, next.
So from other ILDs, they've looked at some trials that looked at the use, particularly of PRAs, and actually a lot of those trials got stopped early.
Yeah.
So in connective tissue disease-associated PAH, the people with substantial ILD burden are excluded. How do you manage those people with scleroderma that have not inconsequential ILD and elevated PA pressure? Are they who 1, are they who 3, and what do you do?
So that's a great question. So for those of you who didn't hear, the question is, in studies looking, because ERAs actually, at least in an animal model, or bleo model, where you induce fibrosis, if you give the animal an endothelin receptor antagonist up front, you prevent the fibrosis. And you can also prevent it in vitro in a cell. Okay, so there were studies looking at both ambrisentan, macitentan, and bosentan in people with whatever, idiopathic pulmonary fibrosis, whatever you want to call it. And actually now it's been done with both with riosequat and all, everything. The bottom line is in every one of those trials they failed miserably. Okay? In fact, to the point that with ambrisentan there's actually a black box warning that if you have true IPF, you should not be on this drug. Okay? Now, why you failed has never been really figured out, but the fibrosis in scleroderma is different than IPF, at least cellularly. It looks different. It responds differently to other cytotoxic agents and stuff like that. However, you do bring up a phenomenal point that I don't know that there's actually a good answer to. How do you tell in somebody who has, say, diffuse scleroderma or even limited scleroderma but has significant interstitial lung disease, whether their pulmonary hypertension is from their interstitial lung disease and the subsequent hypoxia or whether it's true PAH? And the answer is, I don't know 100%. It's sort of like Judge Potter Stewart in pornography. I'm not sure, but I can tell you when I see it. Okay? I'm not sure what it is, but I know it when I see it. The answer is the following. If somebody has like a mean pulmonary artery pressure, when we count them, that's low. Not low, but positive but low, 25 to 30, 35 maybe. I'm not touching them. If they're very symptomatic and or their pressures are really high, look like true PAH numbers, those we'll treat. Okay, and we treat them now currently just like I would treat anybody else with PAH, knowing that I might cause VQ mismatching or stuff like that, but we watch them, and we do treat them. Now, the issue and the reason that we do treat them is the following. If you have both interstitial, there are these people who have really bad interstitial lung disease with pulmonary hypertension. There are, unfortunately, these people who also have really bad PAH with their interstitial lung disease. We know as bad as you do from either one alone, you're going to do worse if you have both. However, currently, the treatment of PAH is actually better than the treatment of the interstitial lung disease as far as outcomes go. Okay? And if somebody's very symptomatic, I'm hoping that if I treat them, I'm going to prove that the PAH is the major component of their symptoms. Okay? Obviously, sometimes I'm completely wrong, okay? And not their ILD, because if it's their PAH, I'm more likely to give them a better outcome than if it's their ILD. That said, those people, though, if they have severe ILD and severe PAH with it, those are the people I'm thinking about transplanting early. So in a lot of those people, I may be treating their PAH just as a tide me over till I can transplant them if they are transplant candidates. Okay?
How does it influence your decision-making of IV therapy or process?
So IV therapy versus oral therapy, I use the same parameters I use for any PAH. If your cardiac index, if you're a functional class 4 or your cardiac index is less than 2, as far as I'm concerned, you're going on systemic prostanoids. independent of your lung disease. Now, do we VQ mismatch people sometime doing that? Oh, yeah. But even if you VQ mismatch them, your body figures this out, and usually within a few weeks or a month at the most, it rematches. So it's okay. But you're right. And that, I mean, to be honest with you, in the NIAMS, we did find that the people who had more, if you want to call it more pure interstitial lung disease had a different genomic profile than the people who had PAH. But there are people who overlapped who tend to have both. So where in that genomic profile that overlap tells you they're more interstitial lung disease or more PAH, I don't know yet. Hopefully we can figure some of this stuff out over the next 5 years of the court. I don't know, since it just got refunded. We'll see. You know, we realized, to be honest with you, so there are two of us who are the co-PIs of this. The other guy's a rheumatologist. We both realized that we probably were stepping into a big morass, and maybe we would get lucky. I don't know whether we have or not yet. I don't know. But to be honest, and the bottom line is we don't care. We got refunded. So that's the whole goal, is to stay funded, right? No, I'm only kidding. Okay, no, actually I'm not. Okay, other questions? Hey, you guys know more than I do. All right, well, thanks. If anybody has any questions, I'll be here for a few minutes. Obviously, it'll take me a few minutes to leave.